Topic: Acute appendicitis in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define acute appendicitis, outline the etiology and pathophysiology of acute appendicitis, describe the clinical manifestations of acute appendicitis, discuss the investigations which can be carried out for the assessment of acute appendicitis, and finally, you should be able to discuss the principles of management, and we will also be looking at the complications of appendicitis. Let's get started. Acute appendicitis is defined as an inflammation of the inner lining of the vermiform appendix that spreads to its other parts. The appendix is a muscular structure that's attached to the large intestine in the human body. It's a narrow tube resembling a worm and is named after the Latin word vermiform, which means worm-shaped. And the word appendix is derived from the Latin term append, which means to hang upon. It is one of the most common causes of acute abdomen. As we understand from the gastroenterology module on acute abdomen, it refers to a sudden abdominal pain occurring in the last 24 hours. It may affect the entire abdomen or a localized area of the abdomen only. Next, let's jump into the pathophysiology and causes of acute appendicitis. Many reports have shown that the inflammation of the appendix is usually caused by an obstruction of the appendiceal lumen from a variety of causes. The most common cause is lymphoid hyperplasia, secondary to inflammatory bowel disease or infections, fecal stasis, and fecalitis. So, the obstruction of the appendiceal lumen can then lead to an increase in pressure within the lumen. Simultaneously, intestinal bacteria within the appendix multiply, leading to recruitment of pus cells and formation of pus, which then causes further increase in intraluminal pressure. If this pressure goes on, the intraluminal pressure rises, finally leading to venous outflow obstruction, and this then causes appendiceal wall ischemia, resulting in loss of epithelial strength and allowing bacterial invasion of the appendiceal wall. This infection can progress, leading to perforation, gangrene, periappendicular abscess, or peritonitis. Now let's look at the clinical manifestations of acute appendicitis. Most common symptoms is of course abdominal pain, which typically begins as periumbilical or epigastric, then migrates to the right lower quadrant. Patient usually lies down with flexed hips and draw their knees up to reduce movements and to avoid worsening their pain. The duration of symptoms is less than 48 hours in approximately 80% of adults, but tends to be longer in elderly people and those with perforation. Associated symptoms include fever, nausea or vomiting, and anorexia. Physical examination findings include rebound tenderness, which is pain on percussion, rigidity, and guarding, which is the most specific finding. The right iliac fossa tenderness is present in most of the patients, almost 96% of them. Of course, let's not forget general examination to assess the patient's hydration status and perfusion in the case of septic shock secondary to peritonitis. The following additional signs may also be present in a minority of them. Roughsing sign, which is the right lower quadrant pain with palpation of the left lower quadrant, suggests peritoneal irritation. Obturator sign, where the right lower quadrant pain with internal and external rotation of the flexed right hip. This suggests the inflamed appendix is located deep in the right hemipelvis. And lastly, psoas sign, where the right lower quadrant pain is present with extension of the right hip or flexion of the right hip against resistance. This suggests an inflamed appendix is located along the course of the right psoas muscle. When it comes to investigations, a bedside scan can be helpful to look at any free fluid collection within the abdomen, which could exclude other pathologies that may lead to acute abdomen such as ectopic pregnancy or ruptured abscess. Urine dipstick test could be useful in excluding urinary tract infection, which again could be confused with appendicitis due to the area of abdominal pain. Lab investigations are not specific for appendicitis. However, they can be helpful in supporting the diagnosis, especially in patients with atypical presentation. So here we can perform a full blood count, which could tell us the presence of bacterial infection through leukocytosis. Raised CRP levels also suggest an active infection, specifically bacterial infection. Very high CRP levels in patients with appendicitis may indicate gangrenous evolution of the disease. Ultrasonography may offer a safer alternative as a primary diagnostic tool for appendicitis, with CT scan used in those cases in which ultrasonography is negative or inconclusive. A healthy appendix usually cannot be viewed with ultrasonogram. When the appendicitis occurs, the ultrasonogram demonstrates a non-compressible tubular structure of 7 to 10 millimeters in diameter. Other than these two investigations, you could also use a radionuclide scanning, which is very rarely done in the case of appendicitis. Localized uptake of the tracer in the right lower quadrant would suggest an appendiceal inflammation. And finally, an MRI can be used in pregnant ladies if graded compression ultrasonogram is non-diagnostic. When we discuss management, it's important to establish route or access for emergency therapy such as intravenous fluids, antibiotics, and analgesics or antiemetics. So when should we start antibiotics? Preoperative antibiotics have shown to reduce post-operative wound infection rates. Choice of antibiotics include, in general, broad-spectrum gram-negative and anaerobic coverage, which is indicated. Examples of antibiotics are piperacillin, tazobactam, and cephalosporins. In penicillin-allergic patients, clindamycin plus gentamicin can be given. Patients with uncomplicated appendicitis require a single preoperative dose of antibiotics only. Antibiotics are also the mainstay therapy for uncomplicated appendicitis, where surgery may be delayed or deemed unfit for surgery. Appendicectomy is the standard treatment for both complicated and non-complicated or uncomplicated appendicitis. The traditional method is open appendicectomy, which is not very much preferred these days because it's not suitable for pregnant women, however done in cases of perforated appendix. A laparoscopic approach has gained popularity in the recent times, especially for uncomplicated appendicitis, appendicitis in pediatric patients, and suspected appendicitis in pregnant women. Laparoscopic appendicectomy is preferred over open surgery for most adults, which also include pregnant women, and is provided an appropriately skilled surgeon is available for the procedure. Finally, let's look at the complications of appendicitis. Important complications to look out for would be bowel obstruction, abdominopelvic abscesses, perforated appendix, and wound infection post-surgery. Due to the nature of the disease and location of the source of infection close to the bowels, one should expect a risk of translocation of gut organisms causing infection, which then eventually lead to an abscess. In summary, acute appendicitis is the inflammation of the appendix. This happens when the appendiceal lumen gets obstructed due to lymphoid hyperplasia, leading to increased intraluminal pressure, which in turn provides a medium for ongoing infection and causes inflammation, venous engorgement, and eventually perforation. Acute abdominal pain is the commonest presentation associated with fever and anorexia. Clinical signs may be suggestive or can help localize area of concern. Important signs suggestive of generalized peritonitis should be emphasized, as this may indicate perforation in the inflamed appendix. Bedside scan can be helpful to exclude other sinister pathologies within the intra-abdominal region, and lab tests are useful to accompany the clinical diagnosis. Management of acute appendicitis focuses on assessing for presence of complications and treating them accordingly if present. Otherwise, initiate broad-spectrum antibiotics, ensuring adequate fluid hydration is provided, and symptomatic relief with antiemetics or antipyretics whilst awaiting definitive therapy. We have come to the end of this topic. Thank you.